From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, listeners. This is Amalia Cochran, the web and social media editor for JAMA Surgery, and I'm here today talking with Dr. Mariam Hantouli.
Hi, thank you for having us today.
And Dr. Giana Davidson.
Hello, thanks for inviting us.
Who are both at the Department of Surgery at the University of Washington. We're talking about their new JAMA Surgery publication, a population-based study of operative versus non-operative management of acute cholecystitis during the different trimesters of pregnancy. I'm really looking forward to talking to the two of you about this today.
Thank you.
Listeners, we do have a couple of abbreviations that are shared in the course of this podcast. ACOG is the American College of Obstetrics and Gynecology, and SAGES is the Society of American Gastrointestinal and Endoscopic Surgeons. I would love to start our conversation by talking about what motivated you to want to look further into adverse outcomes with acute cholecystitis in pregnancy, specifically differentiating pregnant people who did or did not undergo cholecystectomy.
Yeah, I love that question because I think, our motivation in research is such an interesting part of how we design studies. And working at a quaternary referral center, I always joke that my practice is like appendicitis, but in people that have LVADs. And so it's oftentimes this unstudied population. And I think interesting, though not surprising, pregnant people are just rarely included in studies. And it's difficult to know then when pregnant people come in with even, routine general surgical diseases, how we talk to them about treatment options and their disease process and connect with their obstetrics team to really make sure that we're giving them all the information that we have for them to make the best decision for themselves. And so I often found myself talking with pregnant people, trying to explain the state of the data that we had and recognizing that there were such huge gaps, in particular by trimester. And so that was a huge part of when we started talking about this in brainstorming, like what could we do to just contribute to that literature? Very selfishly motivated.
Yeah, and the motivation for me was when my sister was pregnant a few years ago and she was diagnosed with acute cholecystitis. She got conflicting advice. One surgeon told her she needs surgery and it's okay to have surgery during pregnancy, and the other advised against it. So she turned to me for advice, and I was like, I'll look into the newest existing guidelines. I looked at the guidelines, and while they really recommend surgery across all trimesters, the evidence that it's based on is quite limited, as Giana mentioned. They really focused on the outcomes of patients who receive surgery during pregnancy without the proper comparison to patients who do not receive surgery during pregnancy.
I always really like getting that backstory on where questions came from because the stories are, inevitably compelling and they're always fascinating. I would love for you all to tell our listeners more about the MarketScan database that you all used for this study in terms of the benefits and the limitations of that particular database, as well as if there were other databases that you all considered and ruled out.
Yeah. So MarketScan database is a claims-based database that has inpatient, outpatient, and pharmacy claims for privately insured adults, privately insured and employed adults in the United States and their dependents. It gets its data from health plans, employers, government, and public organizations. What's really unique about MarketScan is that these claims are linked longitudinally, allowing us to follow patients longitudinally and examine their outcomes all throughout the pregnancy. However, that being said, MarketScan is limited. And the first limitation is because it exclusively includes claims data for individuals with employer-sponsored commercial insurance. That means that we're missing a lot of pregnancies in the US that are on Medicaid. And so the findings of this study might not accurately reflect the care patterns for patients without commercial insurance. And also, MarketScan lacks data on crucial factors such as socioeconomic status and race, which means we cannot study the impact of systemic racism, both of which can significantly impact adverse pregnancy outcomes. because it's important to remember that effective management of acute cholecystitis depends on access to appropriate evaluation, treatment, and monitoring for complications. And it's crucial to discern those who have access to these components and those who do not have access to these components. We did consider other databases, one of which is the National Inpatient Sample. It's a rich data source. Unfortunately, they also do not have longitudinal follow-up, so we lose all the information. We don't have any information beyond that inpatient stay. So MarketScan was the perfect data source for this question.
It does sound like there are some remaining opportunities for a health equity spin on what you all have looked at, though.
Absolutely. It is always interesting. I'd actually say it's more interesting almost to see within these studies of like who is excluded and whose voice is missing and whose experience is missing. And it really highlights where disparities run all the way through our entire system. Like we can't even get this data easily on those that are like the most minoritized within our healthcare system and have the least access within our healthcare system. So in many regards, we've looked at this as like, hey, here's the best case scenario or likely the best case scenario.
I occasionally like getting into methods questions with authors, and I love that you all used a propensity matching analysis for this. And you all specifically chose nearest neighbor matching without replacement as your technique that you used for your propensity score analysis. Why did you choose that particular technique?
Yeah, this is an excellent question. Thank you. We use this method to make sure that we are comparing apples to apples, which means we matched each pregnant patient with acute cholecystitis to a similar pregnant patient without acute cholecystitis. Once this match has been made, that patient in the control group, the patient without acute cholecystitis, was removed from the pool for future matching. And this is the matching without replacement. As a result of this, each patient in the control group is included in at most one matched set. Using this technique reduces bias and risk of overrepresenting a particular patient in the control group, which can lead to more accurate estimates of treatment or exposure effects. And I think also more broadly, we went with the matching approach instead of covariate adjustment, for example, because it's important to compare each pregnancy to other pregnancies that were viable at the time of diagnoses. And the reason for doing this is to prevent any potential confounding, which is when some other factor is related to both the treatment and the outcome and exposure. We used the nearest neighbor matching, as you mentioned, which means we selected the patient without acute cholecystitis in the control group, whose propensity score was closest to that patient with acute cholecystitis. And if there were multiple patients in the control group with equally close propensity scores, we selected them at random. And that means with propensity scores, we're trying to account for baseline characteristics. So we're trying to compare the outcomes of patients that are similar in propensity scores, but one had acute cholecystitis and others did not have acute cholecystitis.
Moving on to your findings, the one thing that immediately struck me was the precipitous decrease in surgical management of acute cholecystitis during the third trimester, in spite of SAGE's guidelines that recommend otherwise. Were you as surprised by this as I was?
I think that when we talked about like how management might change over time, we sort of had a hunch that there was a technical aspect when you thought, well, you know, the uterus, as it gets larger, it might be very difficult to get the gallbladder out. And then I think second, there might be some sort of thought to be like, you're almost there, you're almost to delivery. And we know that the ACOG guidelines say that pregnant people should get any emergency or urgent treatment just as any other individual should. But then second, they say, and all elective surgery should wait until after delivery. And so I do think that there's a little bit of that push, both from the technical aspect and to the, we're almost to the finish line, that probably impacts the surgeon decision-making and how they make their recommendations.
So there were two findings from the matched cohorts that I would love for us to highlight for listeners and have you expand upon a little bit. The first one was the near tripling of adverse pregnancy outcomes simply from having acute cholecystitis in the third trimester, because this was entirely new information for me.
Yeah, absolutely. That was one of the challenges to say, like, is it the surgery that is causing complications? Is it the disease process or the pathology of the disease itself? And how that sort of relates to, we talked a lot about just like baseline risk as you move through pregnancy to have adverse pregnancy outcomes.
Mm-hmm. It was new to us too.
Mm-hmm.
And that question was very important because when deciding for treatment, you're weighing the risks of just leaving that inflammation there versus performing surgery on the pregnant patient. So that was really important to know.
And I think if we give pregnant people the information and say, well, what we know is if you have surgery, this is your risk, it almost biases them towards like, that's all you've talked about is this one bad thing that happens if you do an operation. So you sort of have to understand the underlying risk of disease itself to have that decision-making conversation with somebody.
Mm-hmm.
I'm glad that wasn't just new information to me. Since this is not my area of practice, I'm always like, is this just completely novel? So that's fantastic. The second matched finding I would love to have you all talk more about is the risk for adverse pregnancy outcomes following surgery for acute cholecystitis was essentially halved. How do we communicate this information to our colleagues to encourage them to move to surgery in patients who are pregnant and have acute cholecystitis?
Oh gosh, I think this is such an important question because how we disseminate data is done in such silos. And then it's only really given to the clinicians and not necessarily to patients. And, just within it's so hard with all the information to read outside your sort of scope of practice. And so I think there's so much work that we as a community need to do about dissemination of information and how to do that effectively and how to do that in a way that patients can access that information as well. And I think folks in the implementation space are making a lot of strides in that. But we have to make the data accessible to patients, I think, as well as surgeons to really allow patients to ask questions and to be able to communicate what their preferences are and at what time. I think for surgeons to understand this data, I think we have to accept that this is one piece of the data about the risk factors for people who are pregnant. And I think it has to fit into the overall picture. And it is our job to sort of put that together in what we know. Because, I am very biased, but this is an awesome study. But it's like one piece of what you would talk to pregnant people about.
Yeah, I agree. The results of the study aim to inform shared decision-making discussions between patients and their surgeons, really rather than telling them what to do, because the outcomes are focused only on adverse pregnancy outcomes. And we don't have any patient-reported outcomes, which may be equally, if not more relevant to patients making decisions about their treatment plans. So it's informing the outcomes on very specific area, but not really all the areas that are important to patients.
I really appreciate you saying that too, because I think one of the things that we forget is people have agency, and that doesn't change when they're pregnant. And so really understanding we shouldn't treat people differently about how we give them information. It's just that the information that they may need is in addition to what somebody who's not pregnant might desire or want. But it doesn't mean that all of their choices for treatment might hinge on the results that are in this study.
That makes a lot of sense. Is there anything else that you think it's important to share with our listeners about your study? Questions you asked, questions that have grown up out of this? What do you think is important that we haven't covered so far?
I think these were wonderful questions that sort of covered, I think, the scope of what we were trying to do for this. I think one of our interests, sort of as a team has always been, who are the subpopulations at high risk and who are the subpopulations that might experience healthcare differently? And so it was a really fun project to do, but it's hard to imagine as a person who does, randomized trials, it is really hard to imagine this ever becoming a randomized trial. We were both a part of CODA, which was the randomized trial for antibiotics versus surgery for appendicitis. And there were sites that didn't want to, their IRBs told them they couldn't enroll women of childbearing age. And it was so disheartening to hear that, like that a group of people, you don't even get to understand their healthcare experiences because they might eventually become pregnant. And so I think it's an area that was fun to study, and we have to think about how to put as much data as we can to help this group of people, make informed choices about their treatment.
I sit there and I listen to that, and there's a woman who's now retired. Her name's Susan Horn, who I had the good fortune to collaborate with a little bit when I was at Utah. And she was very much an advocate for this concept of practice-based evidence studies as sort of an alternative to doing RCTs. And I think, at the end of the day, for something like this particularly, that's really what you've got to do, is do the practice-based evidence rather than try and randomize people into different groups when that may prove to be completely untenable or untenable for a variety of reasons.
Absolutely. And I think it also calls for, I think we're becoming less siloed as a community of folks that do health services research. And there is such a great network of folks that are doing emergency general surgery trials. And I think this is a great opportunity for folks to come together, as you mentioned, to try to better understand this. No single site is going to have enough patients over a study period to really be able to capture the important outcomes.
Dr. Davidson and Dr. Hantouli, thank you both so much for your time and for sharing your expertise with all of us today.
Thanks for having us.
Thank you for having us.
Wonderful to see you.
This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.